Hi, my name is Joe Varghese. I'm a distance learning student from India pursuing my PhD in English literature at the University of Reading. My project is a critical memoir and a study of chronic illness. I'm interested in creative writing, health humanities, theater, and chronic illnesses that do not get the attention they deserve. I want to spread awareness about unfashionable chronic illnesses to encourage better environments for recovery. Thank you so much for agreeing to be a part of this project. You know that health and care workers have a busy schedule, so thank you.
Yes. So thank you very much for inviting me into the session as well. And it's a great privilege. So to introduce myself, my name is Anchu. I work as a lead nurse in NHS and I'm a migrant nurse. So I came to this country um, in 2011 as a student. And as a student, while I was pursuing my studies, almost 2 months into it, I got an opportunity to attend an interview um, within the NHS, and thankfully, I got the job. Since then, I've been working in various roles within the NHS, and I found it incredibly fruitful. And that has led me into my current role as a lead nurse.
Okay, thank you. So before we start with the questions, I would like to introduce this project and what this project is about. So this project that I created is called Acknowledging the Contributions. Recent works that are set in the contemporary time period, like the book This Is Going to Hurt and its adaptation, and movies like Hell, which focused on the carer's perspective during COVID-19, have tried to portray the challenges of working in the UK's health and care sector, and have also tried to represent characters who belong to the migrant and BAME community. The BAME characters usually played the supporting roles in such works, but a significant part of the UK's healthcare workforce comprises migrants from all around the world, including doctors, nurses, and care workers. With the UK health sector recruiting more workers from other countries during the last couple of years, this project is about celebrating and highlighting the actual contribution that they make to the UK's health and care sector. I would like to give such migrant workers, especially from the BAME communities, an opportunity to share their journey and experience of working in the UK. So, my first question is, as someone who's from India, what was your migrant journey like based on your unique stories, based on when you migrated and your efforts to understand the UK's healthcare system?
Right, yes. It's a very interesting question. The journey began as what would be similar for many other migrant nurses. So, once you complete nursing in India, there is a trend towards migrating to a foreign country, which is a quite usual route that many of the nurses take from India, quite historically as well. The same history shared by Punjab as well, isn't it? So, that's where my journey started as well. And when I was preparing to be a migrant nurse, the regulations around obtaining a registration in UK were at the strictest point in terms of English score, language testing scores, etc., and adaptation processes and things around it. Um, so I applied for it, and I came as a student first of all because the agency that I got linked with only did student visas. By then, the urgency in me had heightened quite a lot, and therefore I chose a student life. And also, my parents were also in agreement. So I chose such a route and came to the UK to continue my studies into BSc Healthcare. It proved to be entirely useful for my professional journey because that familiarization into the higher education sector in the country of UK where I migrated to proved to be very helpful for my migrant journey in terms of both career progression and understanding the culture quite a lot as well. So when I finished my studies, within like 2 months, I joined the job sector because my interviews were completed priorhand. And since then, I have enjoyed my journey quite a lot, um, with its challenges as well. The second part of your questions was regarding how my journey was, isn't it? As I mentioned, it was quite a joyous journey, very fruitful as well, with its own challenges that historically a migrant nurse has always experienced. The joyous part of it came from my exposure to fields of specialization within nursing, the autonomy it brings in a different setting as to what I had experienced in India, and also the degree of financial independence that it brings to a woman who has their native socialization that happened in India as a nurse. But these reasons of social hierarchical nature, which kind of mitigated during this process, was something that was quite interesting for me. With regards to the challenges that I had, they are very similar to many other nurses who migrated from India or migrated from anywhere else. Starting from linguistic challenges, understanding the slang, for example, um, understanding the methods of career progression, etc. So, many of my peers that I meet who studied in India, um, when we meet together and we have a discussion, etc., we always say how some of us are probably more lucky, and lucky is probably not the word, um, and I don't know the right word as well, in achieving the career success or the progress that we envisage, whereas some people who are extremely highly skilled may not have had the same exposure for various other reasons, probably because, as some might say, that they were not in NHS and had to go and work in other care sectors, such as care homes, etc. There are quite a few people from our country who have achieved really well in care homes as well, as managers, etc., as educators, etc. But probably the way the NHS is set up may have helped our career progression in many different ways as well. Um, but as I mentioned, it wasn't without challenges. One of the funny stories that I always share in my friend group, I hope we've got time for this, Ale. Yes. So one of the jokes that we always share in our discussions with friend group is as when I was pursuing my studies, I used to work as a carer with a nursing home, and I accompanied a patient for a hospital appointment. So when we go to the hospital, she wanted to use the facilities and wanted to go to the toilet. So she said, I would like to spend a penny. And I did not understand the slang. It was probably very new into my migration status. And she said, I would like to use the facilities. And she pointed towards the toilet. That's how I even understood that she probably wanted to use the toilet. And she looked at me again and said, I would like to spend a penny. I said, oh, you can use the toilets. You don't have to pay anything for that. It's completely free. It's the hospital. Thankfully, and probably embarrassingly, patient's son was with her, who had also attended the hospital appointment. And he said, my mother means that she wants to go to the toilet. And I said, oh, I'm sorry. And I took her to the toilet and assisted her. So these kind of experience sometimes may affect our confidence. But my point is, the more you get familiarized to the social settings that you are exposed to as a new immigrant, the more your confidence would be as well. Now, what improves that social adjustments is probably what you bring with you in terms of your cultural intelligence, your capita, as one would say in sociology, like what if you're exposed to a culture where there are a lot of immigrants, for example, like our culture in Kerala, then you're probably going to show a better adaptability towards things as well, which over time, and now as I reflect back retrospectively, I understand that that was a huge determinant of my satisfaction that I derived from this job as well. So if I had come from a community which was hesitant towards immigration, then it would have been a bit more difficult for me. Then also, within our families in Kerala, there are lots of people who migrate. So that they bring stories to us which better equip us for adaptability. So that probably also helped me. So these are the capita that we bring with us, isn't it? That which we then exert in the new environment that we kind of expose ourselves to. Um, Plus, also, I must say that I found the system rather not so difficult to adapt to because the country by that time was used to immigrant nurses, and they probably gave us some positive confidence towards adapting towards their culture. Uh, this is probably from the historical aspects of when Windrush happened, as you might know, that immediately after NHS was formed. When the Caribbean nurses immigrated during that time. And it was merely by the necessity of things that the society also adapted to the set of migrant nurses. So that culture that was established from 1948 onwards, um, prevalent probably in 60s and 70s, may have adapted, may have helped me to adapt a lot as well, because the country was showing a positive attitude towards immigrant nurses. Now, the degree of that positiveness may be different for different people. For example, it is an undeniable fact that there is snowy white peak in NHS when it comes to the leadership sector. Like the top 3% is completely white in NHS, in the leadership sectors. So why, despite being a heavily diverse, migrant infiltrated profession, at the top peak there is only white population? So why that gap exists, and why we cannot address that gap? Even since from the start of NHS, there had been so many migrant population, and why we that gap still exists is a different question. I've tried to find answers in my own way to those kind of things, rooted in research as well. And the gap is slowly getting bridged as well, which I'm confident about. But at the rate that we want, I'm not sure, because otherwise it should have been so, probably decades earlier. Does that answer
True.
your question, well?
Yeah, yeah. Thank you so much. I was able to understand a lot from that, and
Uh,
yeah, it's true. It is going to take a lot of time, I guess, like in
yeah.
every sector and everything. So, my
Mm,
next question is, what inspired you to study this specific subject and work in the
mm.
healthcare sector?
Yeah, the answer is going to be very boring for this one.
Okay.
Like many nurses who might have chosen nursing at the time when um, we were kind of prepared for professional studies. Many of us aspire to be engineers and doctors, etc. And those few who did not go through the hurdle of common entrance examination may have chosen nursing, and which is finding our calling, as we would say. So that's a joke as well. Like many of my nursing colleagues or the peers that we had when we were doing our studies used to say that, oh, after 2 to 3 attempts in entrance examination, we finally found our calling, and that calling is in nursing. It That's why I mentioned it's probably very boring, and that's how I came into nursing as well. And my quite frankly, my parents said, "You have exhausted your chances. Now you have to choose what we ask you to choose," and that was nursing. I must say, however, that um, even though there are bitter experiences that I received while as a student or while I was uh, advancing in my profession, I may not trade the joy that I received from this profession for any other thing. It has given me immense pleasure through various challenges. Um, and it's probably also rooted in the fact that I came from India, and I did my studies in India, having seen um, the very altruistic sense of this profession as well. So, as a new registrant in India, I worked in regional cancer center, and there I have seen the dedication of nurses and the doctors towards patients who require the utmost level of care in every way possible and quite holistically. Uh, the word holistic was probably embedded into my professional outlook from RCC, from Regional Cancer Center when I worked in there. Um, because many a times, with the limitation of resources, etc., that we have in India, especially during that time, the best thing that you could do for these patients were exhibit the true sense and true skill set. Even if the skill set is the most minimal. For example, um, uh, you might have seen cases where patients would require central venous line to give the chemo medications, etc. So if you insert a central venous line for once, it makes it easier to give the medication. So you can avoid the repetition in cannulating the patient or putting a cannula in the veins of the patient from time to time when you have to give chemo repeatedly. So Well, there are, due to socioeconomic reasons, putting even a CV line can be quite difficult because we may not be able to manage the infection that may be caused to a CV line because treating such infections cost more. So you would resort to putting cannula every time. So coming back to our point, the simple skill set that you would develop by cannulating these patients, and you know that that's the best thing you can do for them without repeat cannulation. If you're very skilled in cannulation, just put one cannula in, and that would be quite a relief to the patient. So you're kind of urged to develop your basic skill set. And the amount of people that you see during your training, the sheer volume of them is kind of multiple times the number of patients you would deal with in this country. So you're kind of skilled in a very proficient manner, both in the number of patients that you can manage and also the basic skill set that you would do. So you come out as especially highly skilled professionals in this, and that kind of earn a lot of respect and patient satisfaction, quite frankly. So I've seen that, and I've learned that from the exposure that I had when I migrated to this country, and that quite helped me in this journey as well. Um, but the other things that I explored and experienced with a lot of satisfaction is the autonomy that you get in your profession. For example, the current job that I'm doing, which is a lead nurse, you have a level of autonomy there to design your service and adapt your service based on the needs of the population or the changing needs of the population. So you don't have to go through a high level of bureaucracy to establish that. Now, obviously, when the resources are limited, because NHS is a part of a welfare state and it's a free service, you have to probably be very reasonable about what changes that you would propose. Um, but that's an understanding part of the entire um, structure. My The point that I wish to make is that for the level of autonomy that I get, I still enjoy the profession a lot in a various aspect as well.
Thank you. My next question is about how do you describe your experience of working in a developed country as someone who's from a developing country, and what are some of the main differences that you can see?
Mm. Um, I guess part of it, I probably, as I mentioned earlier,
Yeah.
in a developing country, because the resources are very limited, your exposure is going to be extremely different from what you see in a developed country in terms of sheer nurse-patient ratios. So that kind of make you a lot more skilled as well. You might think that um, when somebody works in a more relaxed environment, they are likely to hone their skills. Um, it might be my observation, and that might be wrong, but my belief is that it may work the other way around as well. That the more cases that you are exposed to, uh, the more rooted your understanding, your knowledge base, and your ability to link it to the current evidence and to apply the skill set as well would be. Um, in terms of difference, however, yes, the numbers are quite different. The resource availability is quite different as well, or the way the resources are managed is quite different as well. When I came from India, um, a better way to answer it would be how NHS is regarded amongst public in this country. So they consider NHS to be a national asset. They're quite proud of it as well. And that's partly because the way it was established when it first began um, is in such a way that it is an evolving construct. Anything that is anything there where there is an advancement with science and technology in the healthcare, NHS would very proudly assimilate and show it to the world that a um, free healthcare system can provide it, and it's a part of national pride for the population. Think about it in the settings in India. How proudly will we call our healthcare system as pride of the public sector, isn't it? It might be quite different in nature, especially now that all of the younger population also thinks about insurance. My parents, um, I dread if my parents did not have an insurance. So, what I mean to say is that we have enormous skill sets in India and resources in India that should be targeted towards developing a really good public sector as well. I've seen the difference in such a way that when NHS got established, and even from the beginning of NHS, there have been lots and lots of challenges. The birth of NHS was itself based on a lot of challenges at that time, both politically and from the public sector, but from the upper caste of the public sector. So the doctors at that time, when NHS was formed in 1948, were mostly against it, except some socialist doctors. So because of their loss of income, their potential loss of income, there's a very famous quote that I read in probably in one of the papers or archives that Naibavan, who introduced NHS at that time, said that if I have to fill their mouth with gold, I'll do that. That is the doctors. Basically, just meaning that he'll do anything to bring them into NHS, if even if that means paying them outrightly, bribing them. And so when he introduced NHS after these many challenges, you would think that okay, the national policies etc. will provide a lot of funding towards NHS. So it was funded in 48, and in 51 the funding was cut short. So even from that young period, it has faced a lot of funding shortages. But what was happening alongside during that period was that the public were public had kind of accepted this as a part of their life and accepted it as a very positive change. Say, for example, the mothers who had their children just before NHS was established and after NHS was established said that the second child came free because because it was NHS. The changes in the dental care, for example, was enormous as well, because dental care is not, in many cases, life or limb saving. So it doesn't take priority. So previously, previous to NHS, people had to pay for their healthcare, and they had to. If you think about middle class or working class people, it would have been very difficult for them. So dental care took a backseat, obviously, because you can't afford to pay for it. So when NHS was established in the first time, dental care was completely free, not like what it was now. And now it is like part of it you would have to pay, isn't it? At that time, dental care was completely free. So in the first year itself, they said that around 33,000 false teeth set had to be produced because the it was very poor oral health at that time. So there are such interesting snippets, and over time, um, people have kind of assimilated the good values of NHS in such a way that it has evolved to be their national pride. And as I mentioned, NHS showed that strength to be able to produce the best quality healthcare, even as a public sector wing. If when you compare that with India, we kind of, as public, have accepted the fact that because it is provided for by the government, there might be some aspects of substandard service. I'm not saying that that's everywhere in all economies in all states in India or anything like that. We in Kerala, we are very proud of our um, um, public sector health, isn't it? And so these differences that I saw um, amongst the general population about pride for their healthcare has greatly influenced and shaped my thoughts as well in the way that I deliver it. Because when people come to our department, I know that they are more acceptable towards the waiting times of NHS because they know that the system cannot see everybody within a set period of time, whether that's 48 hours or 72 hours, unless it's an emergency. So that level of acceptance is more amongst the public in NHS sector, how much ever negatively it is publicized. And, but yes, and another thing, and quite interestingly, what I see is when I came to the country and knew how I must revise my practice is when I understood the importance of evidence and basing your practice on evidence. The evidence-based practice is kind of um, a norm, and that's how you must practice. It is not a choice. So if I propose a certain change, for example, in my department, I have to show that this has got the best evidence to support it. It's got really good research, um, both in terms of clinical value of it and in terms of budgetary reasons around it as well. Um, Even if it wasn't in a leadership role, if one of our nurses were to see a patient and was meant to give an advice regarding stopping a particular medication before they have their operation, they must go and seek the evidence behind it and see what the guidelines say and how it links to the newer evidence, etc. If the guidelines say something which was older and there is newer evidence now, you can by all means challenge the current guideline and seek your professional peers' support in giving. Whereas in a different setting, especially in India when I was practicing, you just go by what the doctor said. And that's not entirely required here, you know. So those are the differences that I mainly see.
Thank you for that. That was a lot to process, and yeah, I see the difference now. Yeah, it makes sense. So my next question is, what are some of the differences that you notice as a patient based on your own experience when you compare
Mm.
UK's healthcare system and Indian healthcare system?
Yes. So both the public healthcare system in India and British NHS system, they are both welfare state-led uh, structures, isn't it? They're both free for the public. But as I mentioned, the way the NHS was probably set up was based on such good, strong foundations that you cannot deviate from producing a certain standard of work. So you have your commissioning bodies and your regulatory bodies, both of who would look at the outcome of what you do. For example, when I say regulatory bodies, bodies like CQC, they will come and inspect you to see that the quality of work that you provide to the public, whom we are liable to, is up to the standard. And if it drops the standard, obviously you get a poor rating. So you are required by law and by these regulatory bodies to put a really good quality of health outcome out there, and you will be measured against your health outcomes amongst your peer hospitals as well. So if the hospital that I work for has a higher mortality rate whereby patients die, for example, after a specific set of procedures, we are answerable to look into it and see what went wrong, investigate it, and rectify it. The degree of how it happens, etc., may vary, etc. But there is a structure to support the general public in saying that the healthcare that is provided to them is of really good quality. The other commissioning bodies will only give you money if you kind of comply by the standards that they put out, and also you'll cater for that specific number of people as well. So otherwise, the amount of money that you get would be quite deficient as well, and certain services may be taken away from you, is what how I understand the system. So if you're not able to cater for the group of renal cancer patients in the sector that you manage, for example, then you will not be able to get the funding the next year. So you'll have to give up that service, which then in turn affects your income. So even though it's a free structure, the internal governance around budget doesn't work in a free concept. So you, as a hospital, you get the money for the procedure or an investigation that you do, just like any other sector. If it was a private sector, the variation would be different. The expectations and provision of that service would be different as well. But that's how it's meant to work, and you get that concept more when you look at ideas like model hospital, etc. In your further interviews, you might come across that concept. And with the influence of both these regulatory bodies and commissioning bodies, we are bound to be answerable to the quality of the work that we produce before public. And then there is freedom of FOI interest questions, freedom of information questions that we have to answer as well. So we are quite answerable to the public, the regulatory, and the commissioning bodies, and they all are in public domain as well. So if you do a Google search, you can see how much a surgeon's mortality or morbidity rate is after a specific procedure and things like that. So it's out there in the public, and you must publish that data, is the idea. In India, how transparent is this? Is my question. It might be very transparent, and I might be ignorant, and I would happily stand corrected if that is the case. And but as I mentioned earlier in the interview, the core philosophies that I learned in my profession came from my exposure as a student nurse in India because of the sheer altruism, the dedication that we see, and the influence of the Gandhian philosophy, etc., to say that service comes first. So even now, even when we have moved to UK, you're sometimes hesitant to ask for the correct pay that the nurses deserve, isn't it? So there might be such culturally inhibiting factors which are rooted on altruistic philosophies as well, is my experience. But in both systems, I know that both systems work not because of the money that is paid to the people, but primary driving force in both mechanisms is possibly the goodwill of the people that who are involved in this. And that I'm a firm believer of. Does that answer your question? Is there any other aspect that
Yeah. Like, how do you describe about your own experience? Like, as a patient,
ah
when you are in India, like when you are in India, I don't know whether it's a trend or something, but sometimes people kind of
uh,
choose the private hospitals, and
mm,
that is something that's going on here in India because of the
yes.
multi-speciality facilities and everything. So that is
Mm,
completely different there. So as a patient, what is your experience like? And yeah,
mm.
that I would love to know about
So
that.
um, I may not be able to answer that question without a certain degree of bias that I'm very conscious about.
Yeah.
And so I'll tell you about this experience that I had. So my son used to come home from school with a great degree of knee pain for a period of time when he was very young. So he probably was at the start of his year 5 or 6, etc. And he must have been 10 or 11 at that time. And so we used to take him to A&E. There is no preference that you get, obviously, being in healthcare or anything like that. So you take him to A&E, you wait there, he gets his investigations done. The system was extremely prompt with getting the investigations done. So he had an X-ray, bone scan, MRI, etc., and there were no outcome to these investigations. And my husband used to say that he's in a lot of pain because it's recurring, and that's why there are so many investigations being done. And every week, this guy would come home with knee pain, and he is a football player, so it affects his confidence as well. Um, and therefore, in the end, it was my husband who then convinced me to say that, look, let's get these investigation reports, send it to India, and see what they say. So he did that, um, and it it produced a certain diagnosis. We were probably visiting British hospitals for maybe 6 to 7 months until that time to get a proper diagnosis. My core belief as somebody who works within the system is that why would we be worried? We are getting the investigations as required, etc. Every time we go to any, we get the attention. There is no reason to disbelieve the system as well. But what I probably overlooked is the fact that there were not enough skilled people who were reading the MRI, for example, and producing a report or producing a diagnosis. So the MRI was getting done. Was somebody reviewing the report? We didn't get any evidence to say that that was happening, which is why as soon as we send this radiology reports to India, we got the diagnosis. When I tried to later inquire why this was, there was an acute shortage of radiologists. So there are radiographers who would do the investigations, but the radiologist who would make an inference about this investigation report, there was an acute shortage of them. So we even used to send these reports to US to get a radiologist to look at it and bring it back to NHS and things like that. So this part of the delay was not known to me as a public when I approached the healthcare. If I had known this, maybe I would have adapted or used some mitigating efforts to get a report sooner. But I was not understanding what was happening. I didn't knew that there was nobody reading the reports. So that was my experience, one of my experience with NHS when I directly had to deal with it. We then had to take our son to India to get the surgery done because by then we had had enough of this guy going through a lot of pain and he couldn't play football. When we were going through the recovery phase after his first surgery, it became evident that he was bullied at school because as a football player, it's a team plays. It's a team game. And if you can't pull your weight, then obviously your team members are not going to like you that much. And he was a goalie. So he went through a certain degree of bullying as well. So not only did it affect his muscle weakness around when you're not using the knee, the muscles around it go weak. So there was a considerable degree of muscle wastage, which we then had to imply physiotherapy on to recover from that. And then also to get the surgery, we had to go to India. Then also his added to that is his psychological impact it had on him in terms of being exposed to the bullying, etc. Um, but that's it. That was for his one knee. He had the same problem in the other knee as well. So when we took him, we almost knew that it is the same problem. So we took him to A&E again and got the investigations. He got the surgery done within 1 month. So we have seen both ends of the spectrum um, of the same phenomena. So I don't consider myself in a position where I can stand and judge the system in any way, and I don't want to do that as well as a believer in NHS. But I understand the pressures that NHS go through. And as a mother, yes, I have taken my son. But will that make me a non believer in NHS? It'll never. Because I've seen the amount of positive impact it has had on people's life, especially when there is a life threatening emergency and things like that. And that's probably also one of the criticisms that you have heard, that unless you go to NHS with a life threatening emergency, things will be severely delayed because the system is constrained and it's under a lot of pressure. If I don't understand it as somebody who works within the system, how can I explain this to a public if I don't believe in what I am going to say? Isn't it? So I kind of understand the system still, and I believe in it still. And I hope that it will still remain as one of the strongest systems that will be role modeling welfare state healthcare to the rest of the world. How that would translate to India, that's coming back to your question, is if I were to have the class of treatment that he had here for his second surgery, I would have to go into private. Correct me if I'm wrong. And as I mentioned, I'll happily stand wrong as well. But that's it. Is there any point in criticizing or comparing one system over another when we know what limits each system? Isn't it?
Yeah.
My cousin had a life-saving surgery in India in the government medical college, and we know that government medical college saves millions of lives, like almost every month, isn't it? And so each system is faced with its own challenges, um, and that's where the policies or impacting the governmental decision as public comes in. So if I were to demand that I want that quality from the service as a public, then the policymakers will look into these and will enable that, is my belief. There may be again several factors affecting it, like if there is a war somewhere and that affects the movement of goods services, obviously it will have an impact on any system. Those kind of features we would understand, but I'd probably appreciate a bit more of quality regulation so that it brings on more public confidence in the healthcare systems in India. And it would be really nice to see that. And obviously, our state, Kerala, um, can pioneer it because we have a very health educated mindset amongst our general population. And our politicians also know that. So it's kind of bridging that small gap, which will kind of elevate our status and the status of Kerala healthcare much higher, is what I think.
Yeah.
Yes.
Thank you so much for sharing that personal journey, and it helps a lot to kind of say it out loud, and it's kind of something that a lot of people hear, and to hear both sides of the story is kind of something that
Mm.
that we don't get to experience a lot. So thank you for that.
Yeah.
And my last question is, what are some of the changes that you see in the sector with the
Mm,
introduction of AI?
mm,
Does it affect your work?
mm, mm. Um, so thankfully, we are at a place, and this I'm talking as somebody from within NHS. We are at a place where we can understand the importance of AI in the work that we do, and also we are in a position to influence it as well. What I mean by that is, as a part of COVID, for example, and all of the public expectations around service delivery changed. Previously, the department that I um, lead were only providing face-to-face appointments, and those face-to-face appointments used to be an hour to an hour and a half long. And now, because of COVID, patients' expectations changed, and they are more willing to accept those changes, which are virtual clinics, telephone clinics, etc., and even electronic forms of assessment. So this positive mindset that the public is under now, I believe that we must harness it and employ AI into it. So it's a technological advancement which we cannot ignore. But if we intervene at the right time and use the right resources to bring the positive impact of it into into healthcare, it would be of great advantage to us, is what I see. Now, you might think that because it deals with human life, healthcare system may be quite automated. For example, in the earlier case that I mentioned about my son's scan reports, if it was an automated system, it should have triggered an automated result or an outcome as well. But that doesn't happen. But what AI can do is this, isn't it? It can close the loop of healthcare for a patient the way it must be designed. Put very simply, and I'll translate it into our settings as an example. We kind of look at people who are being prepared for a planned or an elective surgery. So depending upon the complexity of the patient as to what previous medical conditions that they have and the complexity of the surgery, we determine what tests need to be done. And then once we receive the test results, we then determine if they need referral to specialist units such as cardiology or hematology and things like that, because they may need plans from these referral units before we send them for a surgery. So this whole process is quite manual now. From the point of making that appointment till we declare the outcome of the patient as yes, fit to proceed for surgery, or no, still unfit, is a very manual process. So if you see the amount of manual interaction in these, you will also see the amount of room that exists for manual errors as well. And the cost of manual errors in healthcare is extremely difficult to manage because it costs people's lives, isn't it? So if a nurse forgets to do, for example, a set of clotting screen bloods, which is necessary for certain type of surgeries, then there is nothing in the system that triggers her or reminds her, oh, you remember you have to do this as well. And if doing that investigation were bound with outcome implications, such as it would have triggered a referral, then that also doesn't happen. So no part of the system kind of triggers this manual errors or highlights this manual errors or help us integrate it into a safer pathway. So it's all kind of very individual experience based and your ability to safety net it, etc., which is quite difficult because of the workload that each nurse faces or any healthcare professional faces. So that's where you can bring technology in. You can automate a lot of processes as triggers, and the level of manual interaction would still stay with the decision making. Or you can set up the system in such a way that there is multi-level decision making happening, and only after that, with human interaction, and only after that you will sign off the care plan for a patient, for example, or in like our case, declare the patient fit or unfit, etc. So my worries are not based on the loss of job, etc., but more about the way we can integrate AI into our healthcare. And I see a lot of opportunity for that because NHS is quite a stretched system in terms of the resources that it has. So correct technology applied at the right time is, for me, it's only good from what I have seen. The promising factors here is that because, as I mentioned, there are regulatory bodies that see them type of involvement in healthcare. Um, there is also a regulatory body to understand what AI each hospital, for example, even purchases. So you might have come across that the fact that each hospital have their own IT systems. For example, our hospital uses a certain IT system called Cerner. Some other hospital uses an IT system called Epic, etc. Each of this IT system have its own capabilities in terms of AI. So, for example, Epic has got a more adaptability towards robotic automations and agile interventions and things like that. It's quite a strong system, but that's not what other hospitals may have. Some hospitals may not even have an IT system. They might still be doing things on papers, etc. So there is an underlying problem of a non-standardized, non-uniform IT platforms that these hospitals are using, which may affect standardization of care. Um, you might find it very difficult to believe that even at this age, when you know that there is a lot of computerization that has happened in NHS already, and we use IT platforms to get the result from, for example, Brighton, which is quite far, not quite far, but far from London, we have to resort to emails. So we email the cardiologist there to say that, can you please send us the last cardiology outcome for this particular patient, which is quite difficult. And many of the public said, public don't believe it. He said, you have everything in the computer. Sadly, we don't have everything in the computer. We still have to resort to emails and other primitive means of communication to do that. So I hope that when we are integrating automation into healthcare, it be on a standardized platform, that every hospital have got the same capability to integrate AI into their working, would be the huge request that I would place before anybody. Do you see what I'm trying to say is
Yeah,
that while I'm very confident about the role of AI, or the potential that AI has in improving the healthcare outcomes, my worry is that the basic IT platform is not similar across hospitals to apply the same AI potential to each hospital. So if our system cannot do automations, and Epic, which is used by one of the other hospitals in London, can do it, then that non-standardization kind of persists, which affects healthcare outcomes as well. And we spend a lot of extra money for lots of investigations and test reports that other hospitals have done. But because this data is not available to us, we still have to repeat all of this for the same patient. So imagine that as well. Anyway,
thank you so much. That was also very helpful to kind of see the technology that is kind of changing around, and
yes,
I don't think the public would understand that without all this information. So
yes,
talking about it makes much more accessible in that sense. So
yes.
that was my last question, and thank you so much. Thank you so much for being a part of this project, and thank you so much for giving me the opportunity to meet with you. Thank you.
Yes, as I mentioned, it was quite a pleasure to talk to you regarding this as well. And all the best, Joe.
Thank you.
Take care then. Bye for now.
Bye.